Welcome to this video on PET-CT in oncology. This video will be divided into two parts. The first part will talk mostly about the protocols, and the second part we will talk mostly about the images. Here are the objectives for this lecture. So there are many types of cancers and malignant cells where they metabolize and have increased metabolic functions, and therefore they have increased metabolism of glucose. Intracellular glucose activity varies with different types of cancer, and a lot of it has to do with how malignant or how aggressive the cells are. Some certain cells, though, or certain types of cancer don't metabolize sugar at all or hypermetabolize sugar. So most cancers, but not all, will. And PET imaging using FDG F18 has become the most accurate imaging tool for diagnosis and staging of many of these cancers that do hypermetabolize glucose. So F18 is a cyclotron produced. It decays by positron emission. It has 511 keV photons with a max energy of 635 keV. The physical half-life is 110 minutes. You may see that written as 109 somewhere, but 109, 110, it's somewhere around in there. And then FDG is the actual radiopharmaceutical. It's called fluorodeoxyglucose. This is a glucose analog, and that means that it will concentrate in cells that rely on glucose for energy, which, as we just mentioned, a lot of malignant cells will do that. And it also concentrates in cells whose pathophysiological conditions demand more glucose, such as the case with those certain types of cancer. So FDG, like I said, is a glucose analog. So it's very similar to glucose and how it behaves in the body. And so it serves as a marker of glucose metabolism. And some types of tumors are hypermetabolic, and you'll see it show up with increased uptake. Others might be hypometabolic in terms of glucose, and in that case, it would take up less of the FDG. So with glycolysis, hexokinase is an enzyme that adds a phosphate. This happens to both glucose and FDG, but the second step is another enzyme that turns the glucose into fructose. This does not happen with FDG, so the FDG then becomes trapped within the cell. FDG avidly accumulates in most cancerous cells for three main reasons. The first is that cancer cells express more numerous specific membrane transport proteins with greater affinity for glucose than normal cells do, and this allows for increased rates of facilitated diffusion into the cytosol. Number two, the hexokinase enzymes in cancer cells transform FDG into FDG6 phosphate at higher rates than normal cells do. And then third, the FDG6-P cannot be further metabolized, and therefore it remains trapped within the cell. Facilitated diffusion is the method of localization. This is the passive movement across the cell membrane. It's a very selective process, though. The kit for FDG, it's provided in isotonic sterile pyrogen-free, clear, colorless, citrate buffered solution. It's colorless, odorless, no particles should be in it. It should be clear, not cloudy. And it gets 10 to 100 millicuries added to each milliliter of the vial, and then 4.5 milligrams of sodium chloride, 7.2 milligrams of citrate ions. pH should be between 5 and 7.5, and there are no preservatives in the kit. So indications for FDG oncology studies, it's for the assessment of abnormal glucose metabolism to assist in the evaluation of malignancy. In suspected abnormalities confirmed with adjunct testing, such as CT or MRI, it's done in patients who have a known cancer, and it's used in patients with coronary artery disease and ventricular dysfunction to identify left ventricular myocardium with residual glucose metabolism. This is also known as cardiac viability. That will be discussed in a later presentation. This one is just focusing on um, oncologic uses of FDG. So indications, FDG PET scanning is often recommended at the first diagnosis as part of the treatment planning and baseline imaging. This is where they are just discovering that a patient has cancer and they're, excuse me, using it to help stage and determine the treatment plan. And then during the treatment, it helps to gauge the efficacy of the treatment and restage the disease. And then after therapy, it's used to help restage, evaluate for metastatic disease or return of cancer. And then, so before therapy, we look at the tumor extent, target lesions, and we get semi-quantitative and volumetric parameters. This is where the baseline SUVs are set that then are used to compare to later to determine if it's responding to therapy or if it's progressing or getting worse. During ongoing treatment, it's used to find new lesions or evaluate the response. It looks for immune-related adverse events, such as inflammation in the area. That can happen if people are actively undergoing radiation therapy, for example. Confirmatory scans and looking at spleen to liver ratios, and then discontinuation of therapy. It's used after the fact to look at metabolic response, evaluate CT residual masses, and then to establish new baselines. Contraindications for FDG oncologic imaging is patients with unstable blood glucose level. Remember, this acts like glucose. It is a sugar or sugar analog. And so if patients have sugar that's too high, like a glucose above 200, for example, it should not be given because it will further raise the blood glucose levels. And then patients who have not followed preparation, that will interfere with the normal uptake and can lead to false positives or false negatives. And then pregnant patients should consult the ordering physician or radiologist. These are indications for FDG for oncological PET-CT imaging. I do want to caution that this is not a complete list. There are a lot of different types of cancer that will metabolize sugar or glucose at higher rates. And these are the most common ones that you will see. And some of these are even fairly rare cancers. There are some cancers that maybe you've never even heard of that are pretty rare. And those patients will typically end up getting FDG studies as well. So the ones that you'll see most commonly are solitary pulmonary nodules, non-small cell lung cancer, thyroid carcinomas, Hodgkin's and non-Hodgkin's lymphoma, multiple myeloma, of course, GI cancers like esophageal or colorectal cancer, even gastric cancer, genitourinary cancers like renal cancer, cervical cancer, ovarian, testicular, pancreatic cancer, of course, will show up as well. And also the other things like melanoma and multiple myeloma, some types of blood cancers can show up as well. So the dose for FDG is fairly consistent regardless of whether you're using it for oncological, neurologic, or cardiac. Typically 5 to 10 millicuries, and it is administered intravenously. And patients should be fasting for 4 to 6 hours, especially for the oncologic studies. Blood glucose levels must be stabilized. So you're going to take that patient's blood glucose levels before you even inject them. Make sure that it falls within the limits. And it needs to be below 150 to 200. No, that says needs to be between. That's the limit. The limit for some facilities is 150. Others, it might be 180 or 200. 200 is the absolute contraindication. Some facilities don't really want to inject it if the blood sugar is higher than 150. There is a lot of patient prep for FDG oncological studies. Patients should avoid strenuous exercise for at least 24 hours. Doctor may recommend a high protein or restricted carb diet 24 hours before the scan. Both of those will help reduce normal variant uptake that could mimic cancer. Patients should be well hydrated. They will fast for 4 to 6 hours before the injection. NPO means nothing by mouth. Water is okay for this test, but a lot of places will say no water either. The height, the weight, the BMI, and the fasting blood sugar all need to be recorded before starting the patient. Patient should rest quietly before injection of course, for brain imaging or brain cancer especially, this is important. But for all the studies, this will help reduce the muscle uptake when we're doing the whole body imaging. No pregnancy. Breastfeeding moms should pump and waist for about a day. The actual FDG decays sooner than a day. It decays in about 12 hours or so. And it isn't really known to go to breast milk anyway, but the FDG is so radioactive and rapidly decaying that you don't really want the baby close to the mom to breastfeed. And so that's why we say pump and waist. And then ideally someone else should give that baby a bottle for the first couple hours after the scan. And some facilities will actually test for pregnancy. Other ones just have a form for the mom to sign. Most other medications are okay to take, and diuretics, bowel prep, and urinary catheters are all optional parts of the protocol. We do want the patient to have an empty bladder before we start. As far as diuretics, bowel prep, or catheters, a lot of times that will depend on a specific type of cancer that they have. Bowel prep might be used for patients where they're looking for anything in the abdomen, but especially colorectal cancers. Urinary catheters and diuretics may be used if the patient has renal cancer or bladder cancer and they want to get a good, clear picture of that area without any urine in the way. And then patients should always void right before imaging. So patient prep, no strenuous exercise for 24 hours, well hydrated, high protein, low carb diet, fast for 4 to 6 hours, no breastfeeding, get their height, weight, and blood sugar. We also usually encourage the patient to use a warm blanket during that uptake period. That will help reduce the brown fat uptake, and we'll talk about that in a minute. So this is just showing the same things. This is from the book. Avoid strenuous exercise for 24 hours. The reason that we do that is to reduce muscle uptake. High protein, restricted carb diet, that helps with the blood sugar and also normal variants. And then well hydrated, that helps encourage the uptake into the cells, so that's great. And then I think I already talked about the use of bowel preps and things like that. The last thing that was on there that I kind of skipped over was the uptake period, which is 16 to 90 minutes, but we're going to talk about that in a second. Patients should be consulted if they're diabetic to determine what their baseline blood sugars are and the extent or management of diabetes. Ask direct questions. Do you regularly perform fasting blood glucose levels? If so, what's your normal levels? Do you have a journal that you do? And then, are there periods of high or low glucose? If they are insulin dependent type 1, you want to schedule them as early as possible in the morning. That will cause less disruption to their normal blood sugar levels and medication schedules. Non-insulin dependent type 2 diabetics may have a light breakfast and schedule them in the afternoon because they just need to be NPO for 4 hours. Have the patient bring all their medications with them though, especially if they have medications for diabetes, because we are giving them something that's a sugar analog that can disrupt their blood glucose levels. Review patient history very carefully and record any metabolic conditions or hormonal abnormalities that the patient knows about. Always watch the patient for hypo or hyperglycemia, and know your policies in your department for managing low and high glucose levels. Typically, if the patient is a little bit low blood sugar, it's still okay to give the FDG because you're giving them sugar. Theoretically, you're helping them. But if their blood sugar is too high or unstable to start, then it may be contraindicated. You may need to reschedule them. You always want to perform a fasting glucose before you inject them, and you may treat and repeat until the patient is within the desired range for injection. Like I said, though, if it's too high, a lot of protocols would just go ahead and cancel and reschedule the patient. Fasting glucose levels should be between 90 and 120. It's okay if it's a little low or a little high to still give the procedure, but you do need to document what their blood sugar was. Some facilities will inject with glucose levels as high as 200, but most have switched to using about 150 as the maximum. And patients with diabetes have inhomogeneous or inadequate tissue activity due to competition with non-radioactive glucose. When your blood glucose levels are really, really high, the cells in your body tend to be saturated with glucose and they're not really taking up any more glucose, which is why it starts to build up in your blood and you get high glucose levels in your blood. So if we come along and inject more glucose into that, it's just going to raise their blood glucose levels, but it's not really going to concentrate in their cells because it's already saturated with non-radioactive glucose. So there's really no point in injecting them if their blood sugar is too high. It's going to raise their radiation exposure and raise their blood sugar to even more dangerous levels, but we're not going to get any of the benefits of imaging because it's not actually going to uptake into the cells. Some patients may require glucose or insulin depending on their glucose levels. Most protocols allow patients to continue normal snacking schedule after they're injected. So this is just an overview of the diabetic patient preparation. Often some departments will have toast and juice and allow patients to have that about 2 hours prior to. Less than 2 hours may lead to increased muscle and soft tissue uptake, and that will compromise the tumor uptake. So that's not ideal. Typically, you do want that glucose below 150. So this is showing you the effects of glucose on FDG uptake. You will take typically an AccuCheck or just a finger prick test of the glucose. Ideally, it should be less than 120 for injection. So image A is less than 110. B is 110 to 159. C shows you what it looks like with 160 to 179 as the blood glucose, and then D is showing you about 180 to 200 for the blood glucose. So you see the visual qualitative comparison demonstrates that FDG uptake in the brain was markedly reduced with higher blood glucose levels, whereas there's really no difference in the liver or the lungs. So if you look at A was the one with normal blood glucose, and then you see how it progressed down to D. And that's because the brain is already saturated with normal non-radioactive glucose, so it's not taking up that FDG. Now, it's always important because diabetic patients can also get low blood sugar, but non-diabetic, I shouldn't say normal, but non-diabetic patients can also get hypoglycemia, especially when we're asking them to be NPO. So it's a good idea to ask patients, is there a time when your blood sugar tends to be lower or higher? Type 1 diabetics, this is usually, it's best to do them early in the morning. Have them fast and not give them any insulin unless it's necessary. With type 2 diabetics, it's typical to schedule them in the late morning or the afternoon and allow them to have a light meal and oral medications in the morning and then fast for 4 hours. And then watch your patients for signs of hypoglycemia. This would be shaking or trembling, faster heart rate, extreme hunger. Sometimes they'll get pale, clammy sweat, and they'll start stuttering or slurring their speech, confusion and difficulty concentrating, and sometimes they'll also complain of dizziness or feeling really tired. This is an example of what an uptake room would look like. Of course, this looks very different depending on, whether it's mobile pet or if it's in a hospital. But patients should either be in a private room or sometimes you'll have more than one patient in a room separated by a curtain or partition. But this is a pretty typical uptake chair. You want your patient to be comfortable because they're going to be sitting there relaxing for about 60 to 90 minutes. And it's always a good idea to make sure they're warm, give them a warm blanket because that helps reduce the muscle and brown fat uptake as well. Now, some PET CT studies call for the use of contrast for the CT portion. It is pretty common to use oral contrast. This can be done with the non-diagnostic low-dose CT that's used just for attenuation correction. So it can actually add or aid in the evaluation of GI FDG uptake. So you really would only need it if you're looking at something that's in the abdominal area and you want to be able to distinguish between tissues. It distends the bowel and it can reduce the FDG uptake there. So physicians can be more confident when they're reading the study in either the exclusion or diagnosis of luminal mural or transmural disease. So disease just around the gut. And usually it's an iodine-based low density contrast. Omnipaque is the most commonly used brand for that. And that little teeny bottle there is only 50 milliliters, so it is really small. The typical dose is about 20 milliliters or so, which is just over half of an ounce. And then that'll be diluted, that should say in 16 ounces. It's typically 12 to 16 ounces of water or a zero sugar flavored water or lemonade. I've seen a lot of times they use the Crystal Light, which is sugar-free, but it kind of masks the nasty taste of the iodine-based contrast and helps kind of mask some of the thickness. It does seem like it's pretty thick and it's really sticky. So mixing that in about 12 to 16 ounces of water, especially if it's flavored water, can help patients get that down a little easier. And we want it to be diluted because even low density contrast can create attenuation artifacts. This isn't very typical, especially if it's diluted a lot, but it is possible. So by diluting it, it just helps to extend the overall bowel and create just basic contrast that helps doctors be more confident in their reading, but doesn't interfere with the quality of our PET images at all. Now, if you're using the low density iodine based oral contrast, patients will drink that contrast mix during the uptake period. So the whole workflow of it, you would get the patient from the waiting room, take their history, make sure they don't have any contraindications. If they're females, you'll confirm that they're not pregnant. And then you take their blood glucose levels and record that, start the IV, inject them. And then during that 60 to 90-minute uptake is when they would drink this oral contrast. Then you have them go to the bathroom right before you put them on the camera, and scan them. And then somewhere in that time, you take the IV out and they're free to go. So patients will drink it during that uptake. High density contrast is typically not used because even when you delete it, that can still create artifacts. Now, IV contrast is used sometimes. IV contrast is only used when the CT portion of the PET CT is diagnostic quality, which means you're using a higher dose. So some states require the nuclear medicine technologists to be CT certified in order to do that. Some facilities, even though the states allow it, will still require the person to be CT certified in order to administer IV contrast or do the higher dose diagnostic quality CT. That can be done pretty much on any PET CT scanner. It's better if it's a larger slice, like 32, 64, or even 128 slice CT, depending on what you're using it for. And then, of course, even if you're CT certified, you still need to be trained in how to give IV contrast and recognize contrast reactions. If it is a diagnostic CT with IV contrast being used, then the parameters for that would follow whatever the CT protocol is that's appropriate for the anatomy. That's going to be different depending on brain, chest, abdomen, pelvis, whether it's a CTA or not, that kind of thing. And there really isn't statistically significant or clinical significant interference with standard uptake values on the PET CT when IV contrast is used. That is important to note because that IV contrast is extremely dense, which is why it's used for CT. But because of that, then it can cause some artifact with attenuation correction. Xanax is another adjunctive medication that's commonly used, and this is only used in patients with head and neck cancer. It will actually reduce the skeletal muscle uptake in the neck area that can impede lesion detection and confound the scan interpretation. When it's used, it's just 0.5 milligrams given immediately after the FDG injection. That uptakes about the same rate as the FDG by the time they get scanned. It will, prevent that additional skeletal muscle uptake in that area. Now, the sample procedure for PET CT for oncology with FDG, you'll verify the patient's ID, measure their height and weight and their glucose levels, and obtain their history. When you're taking their history, of course, you get the height and weight. You do the glucose levels through the glucometer. Usually you just use a finger prick. If you're starting an IV on them, you can, with an angiocath, you can actually get a drop of blood out of that onto the glucometer before you do the connection of the tubing, and that will prevent the patient from getting an additional finger stick. But know your department protocol for that, for what's acceptable for drawing blood for the glucose, and then also what the glucose levels are. If the patient has been properly prepped, their blood glucose levels are good, then you can go ahead and inject them. Never inject them if it's high above whatever is acceptable for your protocol. Inject with, Anywhere from 5 to 15 millicuries. It typically used to be 5 to 10 millicuries, but some of these new scanners will vary in the protocols, and you can actually give a lower dose. So that has become a pretty wide range for what's acceptable for a dose. You'll just have to know what your facility will accept. 10 to 15 has always been pretty much the go-to dose, but these new scanners that are much more sensitive, you may be able to get away with only giving 5. Know whatever your protocol gives. And then you want to flush with at least 20 milliliters of saline. Give the patient a warm blanket and have them rest quietly for about 60 to 90 minutes. Now, typically with oncology studies, you're doing eyes to thighs, so you're trying to cut it right at the base of the brain and not include the really hot brain activity. So that's not so much of an issue with, hypermetabolism in some areas of the brain if they're overstimulated or anything like that. You're really giving them that warm blanket to help reduce the adipose tissue. You want them to be comfortable, but you also want to reduce any excess skeletal or adipose tissue from them being up and walking around or being too cold. Have the patient use the restroom right before imaging to make sure that that bladder is empty. And then position the patient, usually supine. Make sure that they are comfortable laying flat and straight. You can use immobilization devices if needed. And then the first part of the image will be the scout CT. It's usually just anterior posterior image with a very low MA, and that will allow you to set the parameters for the CT scan for the attenuation correction and also for the PET scan. So select the appropriate PET CT procedure, perform the CT with optimized parameters per the PET physician's standing orders and per protocol. You do the scout first, you use that to set the parameters for the CT for attenuation correction and the PET scan. Then the PET scan portion is performed. It's typically about 3 to 5 minutes per bed position. This will vary a little bit because there are a variety of really old scanners on the market that would require longer bed positions, and the newer scanners are digital or they're very fast, and you might even be able to go below 3 minutes per bed position, but that's going to depend on the manufacturer's recommendations. It's usually somewhere around 3 to 5 minutes per bed position, and then the number of bed positions will depend on the patient's height. Now, typically you'll either do eyes to thighs. That's what most FDG procedures are. For that one, you would set up at the orbital meatal line, which is that line that goes straight from the eye to the ear. And that's typically where you would position the patient using the lasers. The scan will start there. Part of that is to reduce the radiation exposure to the eyes from the CT, but also you want to cut off the base of the brain where it has that really hot FDG activity. And typically you're not going to see a lot of metastases above that anyway. So you would cut off right there at the eyes and then go to halfway down the thighs. That's because most cancer that's going to metastasize is going to be around your vital organs, your chest, abdomen, pelvis area, or even, in the lymph nodes of your neck, but that's going to be somewhere between your eyes to thighs. Now, some types of cancer, like multiple myeloma or melanoma, could be anywhere in your body. And so for those, it is important to scan the entire body. And so for that, you would scan at the very top, the vertex, all the way down to their toes. Those scans, of course, take longer because you're doing more bed positions. But for those types of cancers, it is important to scan the entire body. And the CT is typically just used for attenuation correction. There are some places that are able to do diagnostic quality, the higher dose CT with it. And so that's up to your protocol and your state laws. but most commonly it's just a low dose CT for attenuation correction. And then it's reconstructed using iterative reconstruction. I said usually there because standalone PET scanners may still use filtered back projection, but PET CT is iterative reconstruction. So to overview the procedure, you'll identify the patient, have them change their clothes or remove any metal, record their height and weight. You can sometimes get this from the chart, but I would caution that it is really important to weigh them that day because that can influence the SUV values. And sometimes cancer patients can lose weight pretty rapidly. You want to make sure that you're not doing anything that's going to mess up those SUV values. So it's best to get a current weight, obtain the patient history, look at their medications, make sure nothing's contraindicated, measure their blood glucose levels, start the IV on them, inject with, I know the doses keep changing, 5 to 15, anywhere from 5 to 20 is the standard range, 5 to 15, something like that. And then flush with about 20 milliliters of CC. Now, you could discontinue the IV here. Some facilities want you to keep it, especially in diabetic patients, just in case they need something else. And if you're doing diagnostic CTs with it, with contrast, you want to leave the IV in. Give the patient a warm blanket, have them rest for 60 to 90 minutes. At the end of that uptake time, you'll have them use the restroom, bring them back to the scanner and position them supine. Whether their arms are above their head or down by their side depends on whether they're whole body or not. If they're eyes to thighs, then you would put their arms above their head, make sure they have a cushion under their knees, and you can give them that warm blanket again if they're cold. That won't affect the study at this point. It's just making sure they're comfortable. Give them breathing instructions if they need it. If you're doing a diagnostic or more comprehensive CT, then you may need to give them breathing instructions because they may need to do breath holds. But I will caution you that a PET CT scanner to a patient looks the same as a CT scanner. They may not know the difference. And a lot of times when you start the procedure, some patients may think that they need to take a deep breath and hold it because they've had a lot of CT scans in the past. And so you can tell them that they can breathe normally or that they're going to have breath holds. Make sure you let them know what to expect with their breathing. Select the appropriate protocol in the scanner, whether it's eyes to thighs or whole body. Perform the CT scout or localizer scan. This is called something different depending on the manufacturer's name. It may be a scout, it may be a localizer. And then perform the CT portion. Then perform the PET for about 2 to 3 minutes per bed. You'll reconstruct the images. A lot of times these are reconstructed automatically. You're just reformatting them and putting them in the format that the physician wants to be able to read it. Now for total body scan, this gets confusing a lot of times because some places use total body and whole body interchangeably, and this can really confuse schedulers. So it's important that you as a technologist knows which protocol to do. The protocol is exactly the same right up until the point where you image them, and then it's just a matter of how much anatomy you're imaging. A whole body PET is typically starts at the orbitomeatal line, which is that line that goes from the side of your eye to the ear. And that's where you would position them with their laser, also known as skulls to thigh or eyes to thigh. And then a total body scan is the vertex of the head through the toes. Indications for a total body scan are tumors that show high probability of metastases in the head, skull, brain, and lower extremities. So this would be melanoma, multiple myeloma, many types of sarcomas that can go to bones anywhere, osteosarcoma, Ewing's, or chondrosarcomas, for example. And then also Merkel cell carcinoma has a high probability of metastasize to lower extremities or the skull. This is an example of normal biodistribution. Notice in this picture, this was an eyes to thighs study. The top of the brain is cut out of the image and the patient's arms are above their head. Normal biodistribution, the FDG is transported through the cell membrane through facilitative glucose transporter proteins. It's then phosphorylated into the cell and is trapped. The tumor cells have increased number of transporters. They take up more of the glucose and then it gets trapped in the cell. At 45 minutes, the FDG accumulation plateaus in tumors. So technically you could scan them anytime after that. That's the bare minimum. And then at 2 hours, the highest activity levels are seen in the brain and the heart, if they're not fasting, and in the urinary system. And FDG is primarily excreted through the urine, so it's normal to see the bladder being very hot, ureters, and also the kidneys. Normal biodistribution will appear in the brain, liver, kidneys, bladder, salivary glands, thyroid, heart and vascular structures, spleen, esophageal ampulla, stomach, bowel and the colon, the endometrium during menses, bone marrow, muscles, and testicles. You'll also see the thymus in children. Because pretty much every cell in your body uses glucose, the normal biodistribution is varied. So this is another example of normal biodistribution. This is a coronal view at several different slices through the same patient, so you can see how the anatomy changes as you progress, through the patient. This is showing the first 16 slices of the coronal view. That concludes part 1 of FDG imaging for oncology. Please watch video 2 for part 2, which includes all of the imaging review and how different diseases will appear on the FDG imaging, as well as normal and abnormal variants. Thanks for watching.